Hey guys, welcome back. My name is Quick and I'm here to talk to you all about dermatology on the USMLE Step 1 exam. I'm currently in the process of going back and re-recording all of the previous videos with improved audio and video quality to ensure that there is no barrier to you learning this information. So hopefully you see an improvement and are happy with the results. Without further ado, let's jump on into it. This is the first of our USMLE Step 1 question bank series. We will be teaching you how to systematically approach Step 1 questions so that you can maximize efficiency come test day. We will also be hitting on some of the highest yield dermatology concepts that the exams love to test. Anything not covered in this video will be covered in subsequent videos. Our goal with this question bank is to provide for you as many questions as possible at no cost, so that you can master our method and get the score that you deserve. You will notice that all of our slides have the same format. This is to mimic what you will see on the real exam. That being said, let's start discussing the QuickSTEPs method with our first question. Before you do anything, I want you to notice just how long the question is. Now, questions typically range between a few sentences to a paragraph with the lab values, pictures, or sound clips. This format is generally how questions will be presented to you. So, what's the method? Well, you could read the entire question, then the answer choices, and then waste your time rereading the question because you didn't know what to look for in your first go-around. But that is obviously a waste of time. Instead, what I want you to do is to begin reading the last one or two lines of the question stem, then reading the answer choices, then finally reading the whole question while trying to focus on relevant keywords. Now, you may not yet be trained to identify keywords that will help you with these concepts, but that's what I'm here for. I will help you out for the first few questions of every one of these explanation videos, and then provide for you additional questions to practice with on your own. With practice, this will become second nature for you, and save you a ton of time on the exam, which translates to more points. For each question, I will be going over the relevant concepts in a high-yield fashion. I will not dig into the nitty-gritty, so if you are very weak in a particular area, I will show you some content review resources at the end of this video, but I myself will not be wasting too much time of yours going over everything. So let's try to apply the method to this question. Let's read the last two sentences of the question stem together. She states that when she goes outside or is away from the house, her symptoms improve. Physical examination findings are remarkable for boggy and violaceous turbinates. Now, let's read the actual sentence that is asking the question. This type of hypersensitivity reaction is most similar to which of the following? Now let's read the answer choices. A. Anaphylaxis. B. Goodpasture syndrome. C. Contact dermatitis. D. Acute pharyngitis. Or E. Post-strep glomerulonephritis. So already, we know that we're talking about hypersensitivity reactions and that we're being asked to compare similarities. Let's keep this in mind, and now I want you to read the full question, specifically looking for keywords that can help point us towards one of the answer choices. I will give you a second before showing you which keywords we selected. Okay, here are the keywords that I was able to identify. Hopefully what you highlighted has a high overlap with mine. If it doesn't, don't worry. This is your first try, so you'll only get better going forward. The keywords that I was able to find were rhinorrhea, difficulty breathing, sneezing, allergy to latex, away from the house, her symptoms improve, and boggy and violaceous turbinates. So, rhinorrhea with difficulty breathing, sneezing, and allergies to latex are all indicative of atopy. This is further supported by the fact that when she goes away from the house, her symptoms improve, indicating that the allergens are environmental. So, knowing that this question is about atopia and allergies, which type of hypersensitivity goes hand in hand with those? Hopefully you're saying hypersensitivity type 1. This is the hallmark description of hypersensitivity type 1. Sneezing, atopia, allergies, runny nose or rhinorrhea, and watery eyes. You can also get wheals and urticaria. And if it's severe enough, you can go into anaphylaxis, which is actually answer choice A. Let's just go over the other answer choices to see if anything else overlaps. How about answer choice B, good pasture? Hopefully you're saying that good pasture is a type 2 hypersensitivity reaction. What about choice C, contact dermatitis? Well, that's a type 4 hypersensitivity. How about D, acute pharyngitis? Acute pharyngitis does not fall under any of the hypersensitivity reactions, so we can rule that one out as well. How about post-strep glomerulonephritis? And hopefully you're saying it's a type 3 hypersensitivity reaction. So the answer in this case is indeed answer choice A, anaphylaxis. Just remember the hallmark signs of hypersensitivity type 1 reactions, and you know that it goes hand in hand with atopia and the generic picture for allergies that every person has in his or her head. If it's severe enough, it can develop into anaphylaxis. Keep in mind that in this case, it was not even necessary to determine what condition this patient had in order to get to the correct answer. You just had to identify that this question was trying to get you to find the same hypersensitivity reaction. I have included this slide to serve as a high-yield shortcut for everything hypersensitivity related. If you see a puffy patient with their breathing affected, it's a type 1 hypersensitivity reaction. If there are antibodies targeting a specific receptor or a specific cell type, it is a type 2 hypersensitivity reaction. If there are autoimmune antibodies affecting the kidneys, it can be either a type 2 or a type 3 hypersensitivity reaction. A way in which you can differentiate between type 2 and type 3 hypersensitivity reactions is that if it's post-infectious or if that there is joint pain with redness, you want to think of a serum sickness-like condition, which is a hallmark type 3 hypersensitivity reaction. Generally, type 3 renal involvement is due to antibody-antigen complex deposition, while type 2 is the actual antibody messing with tissues or cells in the body. And finally, if you see T-cell mediated destruction of tissue, I want you to immediately think type 4 hypersensitivity reaction. Try to commit that to memory, and let's move on to question 2 and approach it in the exact same way we did for the previous question. So I want you to pause me and read over the last 2 lines of the question stem, look at the picture, and then read through the answer choices. Once you're done, I want you to read over the whole question and pick out the key words. I will give you a quick second to pause me, and then we'll reconvene. Okay, so hopefully you were able to do all of that. Once again, we bolded the key words that we think are key to this question, specifically that the bullae are flaccid, rubbing on the skin results in exfoliation of the layers above, which is essentially just saying that the tissues keep separating every time you brush over them, and that anti-immunoglobulin antibodies are seen in the image, which implies that there is some sort of autoimmune condition. Okay, and then when we saw the answer choices, we see that it's really between 4 things, or 4 different conditions: bullous pemphigoid, good pasture syndrome, scleroderma, and pemphigus vulgaris. So if the bullae are flaccid, that pretty much tells you which condition it is. All of the answers are autoimmune conditions, so which condition best fits the image as well as the presentation. Let's look at the immunofluorescence for a second. I know one of you brainiacs out there are yelling at the screen, reticular net-like distribution. Right? Reticular net-like distribution. If you ever see these words or you see this pattern, it is the hallmark pattern for this condition. I don't want to give it away quite yet, so let's go through the answer choices. What would bullous pemphigoid look like in an immunofluorescent picture and clinical presentation? On immunofluorescence, you will see a straight, continuous line of green highlighting one layer because bullous pemphigoid has autoantibodies targeting hemidesmosomes which anchor the bacillus layer to the basement membrane. Further, the clinical picture for bullous pemphigoid would show non-flaccid bullae that are tense and do not involve the oral mucosa. Rubbing on the skin would not produce exfoliation of the layers above in bullous pemphigoid. So we know that it can't be bullous pemphigoid, which means A and B are out of the running. How about choice C, Goodpasture syndrome? Well, Goodpasture syndrome's pathophysiology involves autoantibodies against the basement membrane of the kidneys and the alveoli. And just like bullous pemphigoid, we would see a linear pattern on immunofluorescence since it is only localized to the basement membrane. However, this patient's condition is affecting the skin, and nothing is said with regards to the kidneys or the lungs. If it were Goodpasture, we would expect hematuria or hemoptysis, or possibly both. So answer choice C can also be ruled out. How about scleroderma? Well, this does not have to do with any immunofluorescence of the skin layers or bullae formation. The cutaneous findings in scleroderma, or at least those that are associated highly with scleroderma, are sclerodactyly, or thickening and tightening of the skin. So we are left with answer choices E and F, which both include pemphigus vulgaris. Now, we actually have to know the autoantibody associated with pemphigus vulgaris, which is anti-desmoglein 3. So choice E is the correct answer. Desmoglein 3 is found in desmosomes, which connect keratinocytes. The keratinocytes are round structures whose borders are highlighted by the green immunofluorescence. If you wanted to be a bit of a gunner, you could also memorize that desmoglein 3 is in higher concentration as you go deeper into the skin layers. That's why in this picture, the top, more superficial part is darker, while the deeper layers are more fluorescent. Okay, great job. Let's look at question 3 and once again do the same thing we did for the previous two questions. Read the last two lines of the question stem, then the sentence that has the actual question mark in it, then the answer choices, and then finally the full question looking for keywords. Pause me while you do this, and then we will reconvene afterwards. Okay, so hopefully you're getting more accustomed to using the method. We highlighted webbing of the fingers, toes, and the creases of the wrist. The pruritus is worse at nighttime, and serpiginous burrows. This is essentially just a pure second-order question where you need to identify what the organism or the infectious agent is and what layer it affects. So webbing of the fingers, pruritus worse at nighttime, and serpiginous burrows is hallmark for scabies. This is the most common presentation for scabies on boards. The next fact you need to know is quite nitpicky. So I'll just come out and tell you if you don't know it, and if you do know it, congratulations. It's that scabies invades the stratum corneum, or answer choice B. Alright, I know that's kind of a know it or you don't question, but you do get a lot of those on boards, and that is just testing how much you know. Let's check out question 4. Now, this is another question that Step 1 and Comlex Level 1 love to test. So let's go through this just like we did with the other questions. Pause me and try the method, and then when you resume, we will talk about it together. Hopefully you were able to employ the method successfully here. This specific question was put in here to highlight the fact that sometimes the question itself really doesn't have much of a relation to the actual question stem. So if you would have read it the first time around in full without doing the method, you may have gone back to reread the whole question, or you may have realized that you wasted time as nothing you read directly applies to answering the question. Just for the purpose of being thorough, however, let's go to the key words that are somewhat related, albeit not very much so, to the question at hand. We highlighted that the patient age increase is correlated with the skin appearing more wrinkled. Now, you do have to know a little bit of biochemistry in order to answer this question, and if you don't know it, then it's a good learning point. Let's go through the answer choices together. Answer choice A, collagen fibril synthesis increases with age. This is actually false. It's the opposite. Collagen fibril synthesis, or the overall amount of collagen produced, decreases with age. That's why elderly people typically have thinner, more delicate skin that is more prone to breaks and lacerations. How about answer choice B? type 4 collagen decreases with age? Although collagen decreases with age, this has nothing to do with wrinkle formation since type 4 collagen is localized to the basement membrane. Answer choice C, there is loss of skin cells over time with age. Skin cells come from the stem cells in the bassalis layer, so we are constantly regenerating them. So this really doesn't have much of an effect in terms of forming wrinkles. By process of elimination, the answer must be choice D, collagen cross-linking increases with age. Now, you might not necessarily think that this would increase wrinkles, but it does. Collagen cross-linking basically serves to contract the collagen a little bit. It doesn't make it significantly stronger, and it doesn't make it better able to do its job. It just forms creases in the skin. So, two big takeaways from this question are that the collagen fibril synthesis decreases with an increase in age, and collagen cross-linking increases with an increase in age. Boards loves to test this concept for some reason, so now you know. Alright, let's move on to question 5. I want you to try this question on your own, pick out your own keywords, select your answer, and then unpause me and we will talk about it. Hopefully you were able to arrive at an answer confidently. The keywords that we highlighted were a farmer, the rash always comes back, and a sandpaper-like rash with occasional scaling. The question asks for what condition the patient is most at risk, and the image shows a slightly scaly, discolored rash. So why did we choose these words? Well, it's always good to look at the demographics. The patient is a farmer. A reasonable assumption for farmers is that they have an increased exposure to the sun compared to the average person. This is an assumption you want to make on the exam. The rash always comes back and is sandpaper-like in nature. These are hallmark descriptions for actinic keratosis. Actinic keratosis is a precursor lesion to answer choice A, squamous cell carcinoma. This is extremely high yield, and I would definitely recommend committing this to memory. So, just to summarize, if you see a farmer with a rash that is described as sandpaper-like, and it is recurrent, you want to consider actinic keratosis with an increased risk for squamous cell carcinoma. So let's move on to the next question. It's very short, it's only 3 sentences, so I want you to read it in full, pick out keywords, and try to confidently arrive at an answer. Okay, hopefully you took a few seconds to do that. The words that we highlighted are on your screen now in bold. Specifically, we highlighted 8-year-old boy, hematuria, and treated 3 weeks ago with penicillin for a rash. The question wants us to describe the rash without seeing it. Whenever you see a child with hematuria after an acute illness, I want you to immediately start to think along the lines of IgA nephropathy or post-strep glomerulonephritis. We know he had some sort of infection because he was treated with penicillin. The way to differentiate between IgA nephropathy and post-strep glomerulonephritis is by timing. Typically, IgA nephropathy occurs within 2 to 3 days after the infection, while post-strep glomerulonephritis occurs 2 to 3 weeks after the infection. In this patient's case, he most likely had a strep pyogenes or group A strep infection that led to post-strep glomerulonephritis. So, what rash is associated with strep pyogenes or group A strep infection? Hopefully, you're telling me impetigo. Alright, that's the first jump, but now the question wants you to describe impetigo. Out of the answer choices, which one most closely resembles a description for impetigo? Would it be answer choice A, white with an erythematous base? No, that's a pretty general description for ulcers and Koplik spots. It's not super specific. But it's definitely not for impetigo. How about circumferential rings of erythema separated by a pale zone? No, that would be more along the lines of erythema multiforme, which is most often caused by herpes infection or mycoplasma infection. How about gold crusted with vesicles? Yes, you should be saying yes. That's the description that you should be associating with impetigo. And if you've ever stepped foot into a clinic and saw a patient with impetigo, you know this very well. It's that honey-crusted, kind of scaling vesicular pattern. And just for the sake of being thorough, a maculopapular rash is used to describe a bunch of different rashes, so it is usually not going to be the correct answer. In general, on any exam, if it's a shared characteristic amongst many different conditions, it will typically not be tested or not be the answer because it is so nonspecific. The USMLE wants you to know what is unique or more specific for each condition. Okay, so just to summarize, the answer in this case is gold crusted with vesicles, because that is the description for impetigo, which we knew the patient had since he has hematuria 2 to 3 weeks after an infection. Good job on that one. Sometimes shorter questions can actually be particularly difficult. And I included this slide just to serve as a high-yield cheat sheet for rashes. If you see gold crusted with vesicles, like the question prior, you should be thinking impetigo with a group A strep infection. If you see vesicles in a dermatomal pattern, especially in an immunocompromised patient, I want you to think varicella zoster, VZV, or shingles. If you see erythema with or without vesicles in the shape of a necklace or belt buckle, you should immediately think contact dermatitis. If you see a patient who has asthma, allergies, high eosinophils, with dry or erythematous skin, usually on the flexor surfaces, think atopic dermatitis or eczema. If you see erythematous borders with central clearing, I want you to think tinea or ringworm. And finally, if you see erythematous borders without central clearing, I want you to think candida. So just commit those to memory, and that will be easy points on test day. Let's move on to our last question for this video. I want you to pause me and try to do the question entirely on your own using our method. Try to get to an answer confidently and don't worry about getting it wrong. After you have selected an answer, please unpause me and then we'll talk about it together. Alright, hopefully you were able to employ the method effectively. I'll read the question out loud and then we'll just tackle it together. A mother brings in her 2-year-old infant to the clinic for poor feeding. Physical examination reveals erythematous nodules on the skin and oral ulcers. On X-ray imaging, you notice the skull has several lytic lesions. A biopsy is taken and electron microscopy is shown below. The cell that contains these features seen below activates which cell type? Answer choice A, T lymphocyte, B, epithelial cells, C, natural killer cells, or D, plasma cells. The key words that we highlighted were 2-year-old infant, erythematous nodules on the skin and oral ulcers, and that the skull has several lytic lesions. So if you're a gunner or you just finished reading first aid cover to cover, well, congratulations, you probably figured out that this was Langerhans histiocytosis. But that really won't help you all that much because you just have to know the general function of the cell involved. For those of you thinking that this condition is low yield, it actually shows up a lot more often than you would expect. So what we see in this picture, that tennis racket shaped organelle, is called a Burbeck granule. These are only found in modified dendritic cells of the skin called Langerhans cells. These cells are derived from neural crest cells, and their function is to activate T lymphocytes. Right, answer choice A, T lymphocytes. So if you were just familiar with this image, You did not even have to know the condition in order to get it correct. Now, for those of you who want to know more, Langerhans histiocytosis is a category of diseases that predominantly affects children. They generally present with a rash and bone lesions. Because the bone lesions are lytic, occasionally the hypercalcemia from the lytic bone lesions can result in polyuria. So just remember, if you see a rash, bone lesions, and polyuria in a child, consider Langerhans histiocytosis. If they give you an electron micrograph with a tennis racket, then you should be pretty confident that the cell in question is a Langerhans cell. And remember, Langerhans cells activate T lymphocytes. Alright, so hopefully you're getting a feel for the QuickSTEPs method. It was designed to minimize redundancy and optimize your time. I know it may seem a bit strange to you right now if you aren't used to using it, but trust me, when you do this for the almost 300 or 400 questions, depending which exam you're taking, whether it's Step 1 or Complex Level 1, it will save you a ton of time and decrease your fatigue. The plan is to work smarter, not harder. Before I go, here is a list of some resources that helped me when I was studying for my exams. All of these resources are very high quality and, most importantly, free. I would highly recommend that you check any of these out. The biggest time commitment would probably be the Anki flashcards. There are a few thousand cards in each deck, but the way that the program is set up is very conducive for improving your long-term memory. Dirty Medicine, formerly known as Dirty USMLE, comes up with helpful mnemonics. Golyan is a series of lectures that go over very high-yield, board-relevant material in an easy-to-digest way. I would put him on while I worked out or cleaned the dishes, and I was able to soak in some more high-yield information while just going about my daily chores. He is very good at breaking complex topics down to their basics and making them easily digestible. And finally, we have the topics covered in this video. If you have any weaknesses, please review the content that corresponds to them. All of these topics and subtopics are very high yield for the exam. Alright, that's it. Good job today. I know the video was a little bit long. Hopefully you're getting used to the method, and I will see you in the next video.